Господа, сейчас мы представим очень интересный концепт, который пока что еще находится в разработке, но, скажем так, это очень большой шаг к интеграции радиохирургии и нейрохирургии. Мой коллега Александр Малесевич представит концепт адаптивной гибридной хирургии.
Good afternoon, good morning, whatever you prefer. Depends on how long you've been awake or not. I will continue where Professor Gansland has left and talk about adaptive hybrid surgery, which builds upon the concept of preservation surgery. Because I don't think anybody debates against the statement that for very large skull-based lesions, like acoustic neuromas, like meningiomas, management of these targets can be very challenging. It is clear that surgery is required to relieve the mass effect compression of the brainstem, all the critical organs. But a complete total resection of the tumor is no longer the preferred outcome of surgery. Rather, we would like to have a relief of the symptoms and a preservation of the functionality. And afterwards, the question is what to do with the remaining tumor. So the question I'd like to answer today is, what's next after preservation surgery? Well, we believe that you should upfront integrate multi-modalities before starting to do surgery. So that means that we believe in an integration of surgery and radiosurgery upfront before any treatment commences for a specific patient. And in this way, you could plan your subtotal resection on the left and your stereotactic radiosurgery of the remaining lesion afterwards, also up front. And the key is here to integrate the two technologies before you start the surgery, so that during the surgery you can be guided towards creating a lesion that is very easily to target with a follow-up radiosurgery boost. Now the whole concept and the whole challenge here is to find this crossing point. What I have depicted in this graph is the associated toxicity. Let's start with the blue graph. So the blue graph are the neurosurgical complications. And on the left, you see that for a large tumor, there are not so much neurosurgical complications. But when you start resecting the tumor, the associated complication rate changes. For radiosurgery, which is the red curve, we have the complete opposite scenario. If you have a very large target, you cannot treat this with radiosurgery because the complication rate is so high. But as you resect your tumor, the complication rate for radiosurgery also decreases. And there is a certain point where the two curves intersect. And what would be the goal of a surgery is to decrease the tumor until you reach this point where you have achieved a residual tumor which can be very safely treated with radiosurgery. Because operating beyond this point would imply associated neurosurgical comorbidity, which would not be justifiable anymore. So how can a company and how can a software assist you during your surgery? Let's take this example. This is a real patient example. Intraoperative images were taken, and you see that twice there have been debulking, three debulking phases have been done. Now, the question, of course, during surgery, you want to know whether your debulking has been sufficient for radiosurgery. Well, we are working on a software that will provide you at any step, at any instance, calculate how a radiosurgery plan looks like for the remaining lesion. And by displaying the dose only in the organs at risk, the surgeon can get a feeling of how safe the radiosurgery plan would be. And you can see that at first, radiosurgery is definitely no option. But after 2 debulkings, the red, the high dose lines, they disappear from the organ at risk and you create a safe treatment plan. If you continue further, yes, it's still safe, but actually this is too much. Because when you engage into this stage, you actually expose the patient to neurosurgical complications which are unnecessary because you could have treated the patient already very safely with radiosurgery at this instance. Now, this software does not exist yet. So in reality, this patient was treated over a course of 1 year. The patient came to the hospital more than 1 year, had 10 days of hospitalization in total, had 10 images taken and 2 surgeries. So this is a very costly procedure for both the patient, for the hospital. It takes also a lot of time, and also the community suffers, of course. So there is a big market, and there is also a need for integrating surgery during and radiosurgery together to reduce treatment and also costs. Now I would like to present you the software we are developing which enables this concept of adaptive hybrid surgery. And at first there is the dual surgery and radiosurgery planning. So the goal of adaptive hybrid surgery is to plan upfront a subtotal resection that allows you the most aggressive radiosurgical approach of the remaining lesion. So the surgeon needs to know upfront how much to resect and where to resect. The radiosurgery plan needs to be safe and effective. So it needs to be ablative, but at the same time protecting the organs at risk. So the software we are developing allows you to plan a reduction of the tumor volume and at the same time indicate the regions of the tumor that are close to organs at risk and need to be better prepared and saved. It's a fully automated solution because we do understand that neurosurgeons have not such a great feeling and an experience in the field of radiosurgery. So all the neurosurgeon has to do is to outline the tumor and select the ICD code for this tumor. Afterwards, in less than 2 minutes, the software will perform an automatic segmentation of all the organs at risk. It will allow to plan a surgical approach and will generate a stereotactic radiosurgery plan, all done automatically. The radiosurgery plan that is generated is depending on the tumor volume. Actually, every time the software will generate 3 different plans. A conventional radiotherapy plan, a 5-fraction hypofractionated radiosurgery plan, and a single fraction radiosurgery plan if the volumes are small enough. So you have always 3 options to choose from. And when you start planning your resection, for example a trajectory, the software automatically updates the treatment radiosurgery plan so you can have a feeling of whether this resection will be sufficient or not. You can not only plan trajectories, but also plan customized resections. And the customized resections is done with this tool. If you move the mouse to the edge of the tumor, the mouse will become this yellow pointer, and you can pick up the contour of the tumor and drag it in to simulate a customized resection, and in this way automatically update the radiosurgery plan. What's also included in the software is a pathological optimization during the segmentation. Where a lot of the atlases fail is to adjust contours of organs at risk if there is compression of the tumor. Well, our software has an optimization which is called pathological optimization, which can take into account these compressions. And also, of course, if you start resecting a tumor, there can be decompression of the organs at risk. Decompression of the organs at risk can also be taken into account in the software to generate a very realistic scenario for your follow-up radiosurgery. So that's all the planning with adaptive hybrid surgery software. Of course, our software also assists you during the surgery and can do that in 2 ways, depending on your equipment. First of all, if you are doing your surgery on the curve system, for example, on the left we show you the surgery plan, and on the right you can see the radiosurgery plan, which gets automatically updated. Now, how can you update the radiosurgery plan? In 2 ways. If you have an intraoperative surgical guidance tool, like the curve or a colibri, you can take your pointer and map out the plane of resection. So all these yellow points are mapped out points during the surgery, and this information gets fed in to the software, and automatically you can see that the radiosurgery plan gets optimized. An alternative would be for the centers who have access to intraoperative imaging, either CT or MR. We will of course use the images that are taken during the surgery and use them to update the radiosurgery plan. Now, as I said, we do understand that neurosurgeons have not so much affinity with radiosurgery. So what we will present during surgery is an overview table where you can evaluate the radiosurgery plan for a neurosurgeon. Let's go. You can see here in 3 columns: SRT, conventional fractionation, hypofractionation, the middle column, and single fraction radiosurgery is the last column. And with red, green, or yellow lights, we can demonstrate whether these organs are protected well or not yet, according to the ICDO guidelines, of course. So this allows the neurosurgeon to take in a judge on the remaining lesion during surgery. Now, what we feel strongly is that this adaptive hybrid surgery concept should be completely integrated into the whole comprehensive treatment. It should start at the tumor board, where the software will assist you to have discussion between surgery, radiosurgery, partial resection, complete resection, because you can simulate any kind of scenario at all. Of course, we assist for the surgical planning, like I showed you, and the radiosurgical planning. Intraoperatively, the plan gets adapted according to the status that you achieved during surgery. And it can also help for radiosurgical referrals. When you have partially resected tumors that you get into your department, the radiosurgical plan gets updated and calculated immediately afterwards. So that was in a nutshell the concept of adaptive hybrid surgery, which is a treatment concept we do understand that a lot of institutes already use today, but there is a lack of software, there is a lack of tools to do a preoperative planning of the integrated treatment. And with Brainlab software, we will allow you to perform adaptive hybrid surgery in a more integrated and comprehensive way. So I'd like to thank you all for your attention.